Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by AGTC, Abbvie, Janssen, MeiraGTx, Novartis, and Roche. We'd also like to thank Accessible Media Inc., our national media partner. Thank you for watching. We hope you enjoy this webinar and share your thoughts with us in the comment section below.
So what I thought we could do today in this session is I can start the ball rolling, just ask a few basic questions, but I know you all have questions. I've already heard some really good ones. So I'll ask a few questions, and then we have Jamie Alexanderson's in the back. She's going to get another microphone and come around, and you can ask your questions as well. So Dr. Kohly, if we could just start out, could you tell us a little bit about what is AMD and what is the difference between wet and dry?
So I'm going to talk in very non-scientific terms so things feel a little intuitive, but you can think of age-related macular degeneration. It's an age-related process. So as we get, as we get older, it tends to get worse. It affects the macula, which is the center of your retina, which is the area that you use to read and to see fine detail. So that's age-related macular, and then it's a degeneration where you get wear and tear of that center part of your retina where you have light-detecting cells, and those cells slowly get ill and stop functioning. And what essentially happens is the retina and the RPE and the choroid, which is the structures in the retina that allow us to see as we age, we get less better at getting rid of byproducts or waste products from seeing. And so those products sort of accumulate under the retina and cause things like drusen and changes like atrophy of the layers of the retina. And that's a sort of a dry form. And occasionally, the body is always trying to self-heal. New vessels form. And when those new vessels form, they're incompetent and they bleed. And that's when it goes from dry to wet age-related macular degeneration. So it's actually the body's attempt to try to bring new nutrients to the area to fight off the buildup of waste, but because these vessels are compensating and are not natural vessels, they bleed and leak, and that's what causes reduced vision in the wet form. So now you can have the dry form where you get buildup of waste, and it never goes to the wet form. You don't get new vessels growing. And that itself can progress where you get more and more buildup of waste, so you get more and more drusen. And then eventually those drusen kind of degrade and you get atrophy, which is essentially loss or death of the cells that are supposed to detect light. So, and in the wet form, when you get bleeding, fortunately, we have very good treatment for that right now to help limit the leaking from these incompetent vessels. People always ask me, like, which one's worse? And it's, 6 of one, half a dozen of the other. At the beginning, dry is pretty good. You can have, it's like I always say, it's like having a few gray hairs. It's not a big deal. And neither is having a bunch of gray hairs, but it's a few gray hairs. You don't really notice it. No one else notices. You're not thinking about it. The early form of dry is like that. Doesn't really have any visual consequence. But in its intermediate and late stages, it does start to affect vision. And same with the wet. When wet is caught very early, it's treatable and you have very good outcomes. But if wet isn't treated, or if you end up scarring despite treatment, which happens in about 10% of people, in its end form, you also lose your central vision. So in early days, if caught early, wet and dry are both very good. You're in a good place. But at end stage, they're both not very good.
So you mentioned treatments for wet AMD. Are there treatments for dry AMD as well?
So the current treatments are vitamins, so ARIDS too, and lifestyle modification, so sunglasses or a hat for light protection, UV protection, not smoking. Smoking's a big risk factor, and eating a healthy diet in green leafy vegetables and oily fish like tuna and mackerel and salmon 3 times a week. There are treatments. I mean, if you look from 30,000 feet, the American Academy of Ophthalmology is happening right now, and this is the latest and the newest things that are happening in retina and all the other parts of the eye that's discussed at the biggest conference in the world. And if you look from 30,000 feet, there are tons of lines of research into treatment for dry age-related macular degeneration. There are 2 phase 3 trials currently, and one of them has been shown to meet endpoint results. So there is one. It is more injections, unfortunately, which will be a big burden on patients to be getting treatment for that, but it's not here yet. And then there's so many in the pipeline, but nothing. Right now, today, it's still the same thing as getting your vitamins and eating well. And really the other thing is checking your eyes every day, because if you convert to wet, you want to pick, time is vision. I mean, if it's a Friday night, I tell my patients, you can come on Monday. It's not 2 days, but if you say, oh, I'm seeing her or him in 2 weeks, you're going to be losing vision that you're not going to get back. So screening is another one. But right now, today, there's nothing in hand that I can give my patients in Canada for dry, but there is tons of stuff coming.
Well, that's a lot to be hopeful for sure. So
there's a couple questions. You want to answer?
Let me do one more question, and then I'm going to turn it over to the room. So
just
we talked a little bit about dry. So could you talk about wet? I know a lot of people are familiar with these injections. There's a lot of different names of different drugs. Could you talk a little bit about the injections?
Yeah, so there are different drugs. There's sort of the 3 that we've been using for a long time: Avastin, Lucentis, and Eylea, and different ones have sort of in different patients work better or worse. So sometimes we go from one to another. So if you do have wet age-related macular degeneration, you're getting treated, your ophthalmologist might all of a sudden say, you know what, let's switch, let's try something different because this one doesn't seem to be getting you out too long. Really, the goal of these injections and what we want, the problem with injections, first of all, injections revolutionized the care of wet age-related macular degeneration, 2005. Before that, we had only treatment that could stabilize you, but you couldn't get vision back. And when these injections and medicines came into the world for actual use, it's why when I was a resident, chose to do medical retina, because it was so exciting. In 1 year, I went and my colleagues went from saying, we can't do much, to we're going to put this needle in your eye and you're going to actually improve. And we watched people improve. It was a very exciting time. Now we have some newer drugs like Buevo, which the whole thing about all the intravitreals that are available, everyone's kind of competing with everyone to get the longest duration of treatment. If you can have an injection once every month, or if you can keep your vision and have it once a year, what are you going to want? Right? So the problem with the drugs that we have right now still is durability, so how long it lasts in your eye. So now we have newer ones. So we have another one, Buevo, which is supposed to last 3 months, but some newer drugs come with some consequences. So there was a small risk of inflammation with this drug, which did make some retina specialists shy away from using it, and others would use it as a last resort. So if you were failing on either Eylea or Lucentis, then you would maybe be asked to go on this drug, but only if it was like, if you had only one good eye that was getting treatment, maybe your retina specialist wouldn't be jumping on that, even though it lasted longer, because you didn't want to have the rare side effect of that drug. And there are side effects. You can get the very devastating consequence of endophthalmitis, which is about 1 in 2 to 3,000, and that's devastating for you, the patient, and for us, the treating retina specialist, because you still can do well with surgery, but you don't often get back to where you were. But it's very rare, and we give these injections monthly or every 6 months, 6 weeks or 8 weeks or whatever duration you're on, because the risk of that is very, very small. It doesn't outweigh the benefits. Now there's newer drugs coming. There's that faricimab is one that's going to be available in our hands very soon. And again, it's supposed to go out to like 16 weeks of treatment. So, you're comparing every month injection or every 3 months to now every 4 months, which is 3 injections a year, which is pretty good. And then there's like the big one I think everyone's waiting for is this port delivery system, where you inject a delivery system that basically allows the medication in the vitreous cavity to infuse out into the retina slowly. So you put that little device or delivery system, inject it into the eye, and then you refill it at 6 months. And so it's really one injection ongoing, and you keep refilling it. So this lasts, the 3-year data just came out at the AAO, and it lasts, compared to monthly injections, the data were similar. So that's very exciting. Now I'm going to toot my horn a little bit for a second. I just wrote a story in the Toronto Star that came out today, actually, on the Insight section on gene therapy for a blinding condition that's often seen in children, which is called RP65, and it results in this retinitis pigmentosa kind of condition. So children are born not seeing. They can have good central vision, but their peripheral vision, and they're blind in the dark. And this therapy was approved by the FDA and the European markets in 2017 and 2018, respectively. And we only had our first kids in Canada get the drug into their eye in August, 4 years later.
And those weren't even covered by the government.
And that's
right?
the whole story. And they weren't even covered by the government. So we have all these amazing therapies. But Mark, a lot of these pharmaceutical companies don't really want to come to Canada because we're so slow to getting them into the hands of treating physicians. So even though this port delivery system is so promising, I don't know how far we are from it, here in Canada.
Yeah, and that goes, earlier our President Doug Rowe was talking a lot about Luxturna, and we were talking about sort of this eye care strategy. So there's definitely advocacy work that we're trying to do to get these treatments to Canada much faster, because it's really unacceptable that it's taken this long.
Now, that being said, age-related macular degeneration is in the top 3 conditions of blindness worldwide, and in North America, in high-income countries, unlike this rare condition where there's only 40 Canadians who have it. So it'll be much faster than what it was for Luxturna, for sure.
Absolutely, that's a great point. Jamie, I think we have lots of questions. So why don't we start out in the audience with this gentleman here in the back?
Yeah, thanks, and I appreciate you taking the time, by the way.
Yeah, of course. Of course. They almost came with me.
I was just listening to your words, and you said something, and I've done the bureaucratic process here in Canada on many different issues of medicine, and I know how slow it is, and you said here in Canada a few times with the treatment for the dry macular degeneration. Are any of these treatments available anywhere else?
No. Those are still phase 3 trials. Yeah, for dry. No. Unless you enroll in a trial.
Yeah, could you clarify the terminology juvenile MD as opposed to age-related MD? That's terminology. But also, you mentioned about the anticipated coming treatments for drying.
You wanted me to comment on the upcoming treatments for dry?
Yeah, but first of all, the terminology. What's the difference between juvenile MD and age-related?
We don't really use the term juvenile MD. So you can have macular degenerations that are not age-related. So you can have a macular dystrophy that is juvenile in onset, and that's an inherited condition that can affect the macula. But I don't really use the term juvenile MD. So we talk, you can have early onset drusen. So typically, we define senior as 65. It's an arbitrary line in the sand. We could define it as 55, or we could define it as 75, but age related. And, so we, occasionally we'll see someone who's 20 who has has maculas that look like they're 60 and they've got a lot of drusen and or like they're 80 even. And so we can talk about early onset. And when we see that, we always have to rule out another condition first. And that's a diagnosis of exclusion. Now, in terms of dry age-related macular degeneration treatments, there's like a subcutaneous injection that's being looked at. There's like a million different treatments that are still in phase 1, phase 2, or at the bench, even like animal models. Nothing close to being in practice now. And there's many things like there's oxidative stress in the cell that affects the mitochondria. So there's targets on that. There's targets on the inflammation pathway. So the drug that is going to come out that's in the phase 3 trial is really affecting what we call the complement pathway, which is involved in inflammation, which is part of what happens in macular degeneration. So there's so many different ways that researchers are trying to break the code of treating dry AMD and to prevent its progression. And it's at many different levels, at the cellular level, at the cascade of inflammation level, and everything in between. It's a, it was a whole session at the American Academy of Ophthalmology on neovascular AMD. It was like there's a few talks on just this and what's in the pipelines, but it's very, very scientific to get into each pathway. So I didn't, I don't think it's, needed to go there,
I was told that there's a light treatment available in England that's approved.
For dry. Yes. This that is you're right. That is new, and that's still in phase 3. We don't have that here. It's a microablation treatment. So there is a treatment that some people do here in Canada for dry. Back to your point, but the data do not support that laser treatment. They do. Let me say that again. The data do not support that treatment of laser for drusen. So drusen are these little deposits that build up in the deep layers of the retina from aging. And so they're made up of like all different types of material, and they look like these little yellow spots when we look in the eye, but they're the sort of beginning of the dry age-related macular degeneration process. And there's actually many subtypes of drusen. If we get into the minutia, there's different types at different layers in the RP, the retina, the choroid.
If a patient has wet macular degeneration in both eyes, is it risky to get cataract surgery?
I mean, so this is my baby. This is what I do. I do medical retina, so I don't treat retinal detachments, but I treat all macular diseases and people born with inherited diseases. There's no treatment other than Luxturna, but I follow these patients once they're adults, and I do cataract surgery. And the answer is, so the surgery itself, occasionally when you're getting repeated injections, you can hit the lens. The lens can be hit, and it can occasionally, like maybe 1 in 100, maybe 1 in 500, it's rare. When you take out the lens can slip to the back and you need a second surgery because the injection itself has touched the lens in some way at the back. So that's the surgery itself. In terms of progression of age-related because of surgery, the data aren't borne out in that. So no, I mean, occasionally, you take out someone's cataract that's very dense and you see, oh, they're bleeding in there, and you didn't see it before because you don't have a good view. Was that the cataract surgery or was that there before? Probably it was there before. And occasionally, you get someone who has surgery and something happens, but it's coincidence. That it has not borne out in the data that cataract surgery is not a risk for progression of dry or wet age-related macular degeneration. The only risk is sometimes the surgery can be a little bit complicated.
Okay. With the ARADS formula, I understand there's a bit of controversy about some people reacting badly with the zinc.
Yes.
It sounds controversial. My retina specialist says it's a money-making thing for the gene testing people.
It is controversial, and the part of the controversy is the people. Some of the people. Anyway, the bottom line. I don't want to get into the controversy and the politics, as I don't know the minutia of it, so I don't want to put anyone down. But the bottom line is the American Academy of Ophthalmology. It's controversy in the literature, and the scientists are battling it out. But the AAO, which is sort of the gold standard, still recommends vitamins, and so we still give vitamins. There are people that get genetic testing, and then they'll be told don't do it because the areas can actually cause harm, but that has not been borne out in the data that sufficiently enough to stop us from recommending and stop the guidelines from recommending giving vitamins.
Are there different types of vitamins that people?
Well, there are, but you really want to follow the AREDS 2 formulation. That's the one that's been studied. So like there's many companies that are making eye vitamins, but it should say AREDS 2 formulation. So it's the right proportion of each of the minerals and vitamins. AREDS. AREDS 2. Wow. What's your secret? Yes. Okay.
But after 5 or 6 years of injections, I reached a point where no further improvement can be made, and I've no sight now in that eye.
Mm-hmm.
But my left eye is 20/20.
Amazing. Yeah.
And so I'd like to know, is there anything I can do right now? Say, oh, I've been told that if you have it in your one eye, you'll get the wet, what is it called, the macula in the other eye.
Mm-hmm.
Is there anything I can do right now to sort of ward it off as long as possible?
There are. I mean, all the things I said before. So, don't smoke, which you don't do. Eating a healthy diet. So, green leafy vegetables in particular. We're not talking about, iceberg lettuce. We're talking about the dark leafy greens and oily fish. So salmon, tuna, mackerel, those types of fishes 3 times a week if you can. You don't like fish, I can see. I'm a vegetarian. I don't eat fish either. So so you can. I mean yes, you can yes, you can if you don't eat fish. It's omega-3 fatty acids. Yeah. So. But that was removed from the AREDS formulation, if anyone's going to say that. But we still always say eat healthy if you can. But so basically, there's sun protection, eating well, and the biggest thing, and it's easier for you because you only have vision in one eye, is if you detect new distortion, you need to see your ophthalmologist right away, because that could be a sign that you're converting to wet. And the sooner you get it, the more likely the injections will be successful.
What sort of symptoms are you referring to?
A drop in vision or new distortion.
So when everyone, sorry to interrupt, so everyone has in their blue bags today that they got when they came in an Amsler grid. So maybe you could, if you don't mind, Dr. Kohly, talking about an Amsler grid and how that could be used as a tool.
The Amsler grid is very good, and it's sort of what we tell everyone to use if life were straightforward and we were at the same place every day. But really, you don't have to use an Amsler grid. You can use anything straight. So if you forget one day or you're traveling, I have patients like, I didn't have the grid with me, so I didn't check. And you don't have to have the grid to check for new distortion. You should make a habit. It takes 1 second to cover each eye. Whether you have age-related or you don't, everyone should do this. And just look at something straight and make sure it's straight. And if you make a habit of doing that once a day at different distances with different straight things, it can be, just look in this room. How many straight things are there that you can look at? There's no shortage of straight, vertical, visual things in our world. So look at anything straight and notice, if you notice after, you have to cover one eye properly and notice if there's any distortion or if things are getting blurrier. Now, sometimes it's dry eye or, you're just the surface. So, you check and, it's kind of weird. And like, I'm just going to wait a few minutes and I check again and no, it's still there. Then if it kind of goes away and then you check again and it's back and it goes away, you probably don't need to worry because that's probably just your surface of your eye. But if it's persistent and it's a new distortion, time really is vision in getting that injection in your eye.
But are you recommending also these know why, for some reason, they make me nervous, the thought of taking them.
Yes, we 100% recommend them.
You do?
Yes.
Can you take too many of them? Because I bought a quantity of them, which had something like 500 mg or something like that. But I also take multivitamins that have this lutein.
You have to be careful. You
Can you take too much?
Yes, you can take too much of some vitamin. Not all vitamins are benign, so you do want to make sure. Just take your bottles into your pharmacist and say, "Am I getting too much, of these vitamins? Too much C or too much E or whatever." So yes, you can take too much vitamin, and it can have other consequences on other organs. So you do want to make sure that you're not overdoing it for sure.
Because for some reason, I was a bit nervous of them. I don't know why, but perhaps it was the quantity was bothering me.
No, so just go to your pharmacist.
And it's overdone.
Thank you. I think there was a couple questions over here. Thank you.
Good morning. I have macular in both eyes. The one eye I had injections for 10 years, and they've stopped that because it's not deteriorating any further. The second eye, I'm taking injections, and it seems to be stabilizing too, so I'm very lucky. But I have a 35-year-old grandson he's had his genetic data analyzed, and they say he probably will have macular as he ages. Now, he drinks a lot. Is that a problem?
Yeah, it can be. You can, yes, smoking and drinking a lot can not necessarily, well, it's bad, it's harmful on the retina, but also on the optic nerve. So, drinks a lot is a, and, the big thing for you, what I would like to tell you is that's 15 years away. That's like, we will have ophthalmology as a field is moving so fast that I'm pretty confident we will have treatments that are even better than we have now, or that even we can't even think about right now, that are going to be good for him. So I would not, as you're being the grandmother, live in like, oh my goodness, I've given this to him and he's going to have to go through what I went through, and will it be like all those worries you might have. I would hang my hat on knowing that on progress, because there's so much progress happening.
Thank you. I have macular degeneration. I've also got glaucoma, which I take drops for, one wet and one dry for the macula. I have a very strange problem that I deal with constantly. Everything I see is kind of cloudy. It's like I've got a cloud in front of me. What is doing that? It's just so frustrating. I can't, I look at people, even right there, it's hard to see her face because it's cloudy.
Have you had your cataracts taken out?
A long time ago, yeah.
Okay.
My cataracts were taken out when I think I was in my 60s and I'm 89.
And does the fluctuation come and go, or is it there all the time?
No, it's all the time.
So-
What a weird question is that was a long time ago, and they had just come out, he put the long distance one in the right eye, and in the left eye, he put a multi-vision. Would that be causing anything?
No,
I
no.
can't read.
No.
Even with a strong
That is
magnifying
that.
glass, I have to read very carefully, only with a magnifying glass.
Yeah, so the path for you at this, it's the wear and tear and the degeneration. I mean, I haven't looked at your eyes, so I can't say for sure, but unfortunately you have two conditions, one that affects your periphery and one that affects your center. So both left untreated, you would lose both. Whereas if you only have age-related, if you only have glaucoma, at the end stage of glaucoma, of course, you lose everything, but you can maintain your center vision and still lose your peripheral vision in glaucoma. And in age-related, it's the opposite way, but you have both. But I don't know, because I haven't examined your eyes, but just based on what you're telling me, many people with advanced age-related macular degeneration, dry or wet, complain that they can't read. And so you have to get these magnifiers.
Thank
It is a very common, and there are, if you go to the CNIB, they have the CCTV, or you could put stuff in. Or actually what I've done for some of my patients is I've actually gone on Amazon and ordered +5, because it's very hard to get +5 readers. And often they go up to +3 or +4, +5, even +6. And I just hand them out to my patients and say, try this and order more if they help you. Most of them say they don't, but occasionally someone says it does. So
We also have in
I
the,
got the +5 and +4, which is useless, but I also was able to get the +7 at the
yeah, you can keep going +7, and it's huge and it's hard, but it may actually help as long as you can get some way of reading. And I have to actually say iPads and all those devices also help, because you can reverse the contrast, so you can have white letters on a black background. You can make them bigger. It's harder to read, but if you have a bigger pad, you can kind of make the letters quite large and still be able to read whatever it is that you want to read.
and we have some great resources here today. I know there's a couple low vision specialists at the CNIB table. Oh, sorry. Yes, of course.
You're right.
are.
I'm
I
so
know
sorry.
Vision Loss
It's the
Rehab.
same with Fighting Blindness Canada. I have
know.
5. It's like, it's so
Well,
enshrined.
We have both CNIB Smart Life here with lots of assistive devices, and Vision Loss Rehab Ontario with our low vision specialists, and Dr. Anna Drusick, who is a low vision optometrist, are all here today. So I do encourage you to visit everyone as well and see what other resources.
Those aids are not to be minimized. They can really help.
They don't affect your eyesight over a period of
No, I get people asking this all the time. It's often like the partner saying, she's on the phone all the time. And no, you can use your eyes all you want. It's really that they want the attention and not be directed to the phone, but you can use your eyes. The only thing you don't want to do is like stare at the sun, but otherwise you can use your eyes as much as you want. In fact, even when your eyes are closed, your visual cortex is always firing away at baseline.
It's been suggested that I get one of these, I get injections for wet. And could you give me the name again about the one that you recommend for longer periods?
It's tricky. You're asking me to favor, but I actually now use a lot of Eylea because it lasts longer. I use both. They're all, you know what? It's actually, I use Eylea, I use Lucentis, probably 50-50. I even, in some patients who don't have coverage who are younger, I use Avastin. The point isn't which agent. The point is whatever agent you're started on, if it fails, like you can't get out to beyond 8 weeks at least, then you may want to switch to another one. And sometimes none of them can get you out beyond 8 weeks. I've got some of my nice people at the back there, so I don't want to feel like I'm being impartial.
I would like to know about glare from the light, from the natural light,
Mm-hmm.
but also from the computer and from the television. Do any of these damage, or I know we wear sunglasses, but are they damaging, or is it to make us see better?
Well, the glare doesn't help you see better. The glare limits your vision, right? The glare limits your vision because it creates glare. So, but glare doesn't in and of itself, I don't believe, unless there's something I haven't read, damage your eyes. It's just limits your vision. So, when we do, going back to cataract surgery, you can have glare at night after cataract surgery, and that can make you seeing while you're driving at night more difficult. But glare in and of itself reduces your vision, so you may not be able to do the things you're doing as well as you could do.
But it's not damaging, it's making it difficult.
Yeah, there's theories of like UV light reflecting off of a screen that could damage your eyes, but maybe someone in the audience may know better than I, but I don't think glare in of itself is causing damage to your macula.
Hi. I was diagnosed with macular when I was 50, and my ophthalmologist kept saying,
50?
"So young." Yes,
Yeah,
50.
yeah.
And I'm now 65, and I've been doing injections probably for 5 years. And I'm intrigued by all of the new things that are coming, and I love the idea that in 15 years there could be better treatments. But I wonder whether those treatments will be working for people who are older than 5
Yeah, well,
years.
this port delivery system was done on patients who had had up to, don't quote me on the details, but I think 23 months of injections. So, a lot of the newer treatments, first of all, have to stand up and show non-inferiority to what we're currently doing. So they need to be just as good. But a lot of them are going to be tested in later trials, like phase 3 trials in patients who are getting a treatment and now are going to go into a trial getting a newer treatment. So 100% yes. It's not like, oh, I'm on the, 8-weekly interval with this drug and that's my path for life. Like as new things come up, you're going to be switched to newer things.
I guess what I was really wondering is, does age have an effect on the efficacy of the newer treatments, or should it not? Do you get the less effect?
Well, the older you get, the worse your age-related macular degeneration sort of gets, right? Like there's an underlying dry component to the wet part that is still progressing. So in that sense, if you've been on treatments for 20 years, your outcome may not be as good as if someone who is the same age who just became wet in their retinas but hasn't been having treatments and hasn't been having that much damage, underlying damage ongoing. So, but I think what you want to hear, and I think what I believe, although I can't read the future, is that you will be eligible. If you're still eligible for treatment, these newer treatments, although you may have lost a little bit because you started earlier, you still will be eligible for the newer treatments, which will ultimately have longer durability and fewer injections. And I'm only talking about port delivery. There's gene therapy that might be one treatment that could cure in a way effectively your wet age-related macular, dry age-related macular degeneration. There's so much stuff, stem cells, there's all sorts of stuff that's happening at the bench level, that will come out, that will will revolutionize what we're doing, the treatment of both these conditions. So stay hopeful. It's like the most important thing with vision loss is to remind patients to stay hopeful, especially because of all the organs in the body. If you have eye problems, you're very lucky because it's so ahead of the game in terms of we can see the disease often. Like the therapeutics and the innovation for eye diseases is so leaps and bounds above other areas of medicine. So if it's so devastating, but on the other hand, it's an organ that is so amenable to new studies and new treatments and new innovations. So always maintain your hope with your vision and your vision issues.
Great. Sorry, I forgot to ask this question on the last one, just with treatments in countries. You look at stem cells. Panama obviously allows a lot more treatment, and so for people around the world go there because they approve treatments that you can't get anywhere else. When it comes to eye treatment, do you find other countries are prone to approving certain treatments faster? What ones tend to approve things faster than Canada?
It's outside my scope. I don't have a good survey of what's happening all over the world in terms of care of age-related. I know what's happening in the U.S., which is sort of our gold standard, but we're at trials. We kind of look to the U.S., we look to Europe, some European markets, but I'm not the right person to ask for that question. I apologize. But if we look at Luxturna, Canada was late to the game. Like I said earlier, it is a rare condition, and it was approved and being given years before, in months to years before in other places. So, we are behind. And when you talk, Doug Earl's you want to speak on this, Doug?
I just wanted to talk about stem cells in Panama in particular. The Canadian Ophthalmological Society, so the professional organization that Dr. Kohly is a part of, has a statement about stem cells. And if you're involved in a clinical trial where you're paying for a treatment, then I would strongly encourage you to seek a health professional, your eye specialist, to speak to, because that is not a clinical trial, I would say. And secondly, the statement from the Canadian Ophthalmological Society is that the stem cell treatments that take place outside of Canada are not proven. to work. It was actually in this room when we had Viewpoint back in 2019, actually, when they were doing, I don't know if any of you attended, the stem cell groups were doing the hotel, having information sessions around the hotels in the GTA. They're not proven treatments, and we have not had efficacy, i.e., proven rigorous clinical trials to prove that stem cells for AMD work. There are clinical trials happening for AMD with stem cells, and if you want further information about them, please call our health information line and reach out to it. It's one of those things that Morgan is going to send in that email. If you didn't get all your questions today, you can ask the health info line, and we'd be happy to provide you that information. It is on our website, but I think I need to do a public health service announcement around stem cells and AMD. It is not a proven treatment.
And not just about efficacy, but also safety, right? Like there's no, the trials that are happening, as far as I understand, with stem cells and AMD are in very early phases.
Very
so
early.
We don't know what is actually safe.
Yeah, and I mean, I have patients who get very, they're very distressed. They're often young. We're not talking about the age-related macular population on average, who, have gone and spent thousands of dollars on acupuncture. And then they come back and say, well, I'm no better. Or they've come and said, give me all my notes. I'm going to such and such country and they have a treatment. And I warn them, I tell them exactly what Doug has said, that these treatments have not been demonstrated on the standard of care that we expect before we provide a treatment for our patients. We don't just, paying for being involved in a trial is something you would never be allowed to do in this country. We have standards of what we consider scientific rigor. And until those metrics are met, we don't follow those treatments. And that's very important because many patients have lost lots of money chasing these types of treatments. Not necessarily for age-related, but inherited retinal dystrophies for sure.
It's odd that you brought that up now because I know the gentleman I volunteer with the CNIB has been in contact with the Mayo Clinic, and he thinks that there's possibility of getting a trial for his AMD.
For sure. So I do direct people to the Clinical Government Trial website where you can look at registered trials all over the world, but mostly in the US, where if someone wants to go and they're eligible and wants to participate, there's programs where you can have funding covered to go to the US to be involved in trials. That's a totally different thing than what we were talking about. So yeah, some people will travel to go and see if they're eligible. In fact, I've sent patients, with choroideremia to Dr. Ian McDonald in is he in Edmonton? Edmonton, or, there's nothing wrong with movement. There's nothing wrong with getting other opinions. If, I don't recommend that you do that for garden variety, sort of everyday age-related macular degeneration, just like you're not going to get a second opinion on your blood pressure medication. You keep working and you have trust in your care, the people providing your care. But, if you want to participate in trials that are registered and that follow the right ethical protocols, by all means, that there's nothing wrong with doing that. I don't think either of us are going against that. We're just saying treatments that have not been proven rigorously in different parts of the world are not advocated or supported.
Just in the initial phases, but I thought that you would have to pay something so that you think, is it okay?
Usually again, this is not my area, but there are pathways if you're involved in a trial that the pharmaceutical company will cover a lot of the funds. If it's like a rare disease and there's no treatment or certain things like that, there are pathways that you can go through to be involved in clinical trials in the US.
Okay, the other quick question is, he has glaucoma, and he's worried that for his wet AMD, if he gets the injections, that's not going to be good for his optical nerve.
It's a very, very, very good point, and he should be a little bit worried. We know that the pressure does go up a little bit every time we give an injection. It's usually very transient, lasting seconds, but this is debated always at every retina conference. There's a glaucoma person speaking, saying, listen, remember about the optic nerve, it's not all about the macula, and occasionally some patients do get 2 needles. They get an injection, and then they get an aqueous tap where we take out a little bit of fluid from the front of the eye to balance what we've put in. And those people with advanced glaucoma, we do that in as a way, or we also put them on topical, like all the topical medications. Their glaucoma has to be controlled, and then if we still notice that there's optic nerve damage happening, or the glaucoma person's noting that, then we put fluid in and we take fluid out so the pressure's neutral.
Okay, because he stopped his treatment, he wasn't quite trusting it for quite a while, and then he had another injection and he's lost his sight.
When you stop your treatment, like I have patients who need it and stop it for whatever reason, they've convinced themselves they've lost trust in the system, or they don't notice a benefit. You can't go back most of the time when you stop treatment.
Thank you so much.
We have time for one more question. Oh boy. All the hands up. Is there anyone in the back that we missed? Because no? Okay, yeah, then come on.
You commented on acupuncture. I underwent 20 treatments for acupuncture, and my purpose was not to improve the eyesight, but to affect the rate of deterioration. Any comment on that?
I don't think there's any scientific evidence to support that as far as I know. But, all of, I don't even know if I should go down this path, but there's a lot of things, taking turmeric, eating blueberries, like there's all these things that, that are probably harmless to the body, but they might be costly. So someone who's spending thousands of dollars on acupuncture, that's affecting their whole life because they're, compromising their money in other places of need. But there are lots of things we all do every day, like eat good food and avoid, that not everything, like smoking, all those things have been studied, but not every little thing we eat has been studied, or every little thing. So it doesn't mean that it's bad, but you just have to be careful. It has not been demonstrated to help. And that's what we as physicians go on. We are not naturopathic doctors. We are not Chinese medicine or acupuncturists or any of those things. So we go on the data that, the medical community and the scientific community rely on to implement treatment and to approve it. These are all things you're doing outside of, it's not government funded, it's not, So I can just tell you there's no evidence demonstrating that is efficacious.
Okay, I think we're going to have to leave it there for today. But thank you so much.
We can talk after.
Yeah, Dr. Kohly will be here for a few minutes after. So thank you so much, Dr. Kohly. That was really informative. Thank you so much.